Dear colleagues, this is a developmental cataract. The patient is a 7-year-old girl. I've taken up this case for surgery. Let us watch the surgical steps. The main incision has been made. This is a 2.8 millimeter incision. This is a side port on the left side of the main incision. Now I'm going to stain the anterior capsule with trypan blue dye. I inject an air bubble, and underneath this air bubble I inject the trypan blue dye. This dye, it is said that it alters the elasticity of the anterior capsule and capsulorhexis becomes easy if we stain the capsule with trypan blue dye. Now, viscoelastic substance is being injected. This is HPMC, that is hydroxypropyl methyl cellulose. Now, another stab incision is made on the right side of the main incision. And now I'm going to do capsulorhexis. See how it is being done. This is a 26 gauge bend needle. The anticapsule is incised and the capsular tag is raised. This capsular tag is held with a utrata forceps. Here goes the utrata forceps. I hold the capsular tag and the capsule tends to go to periphery immediately, and you must have that balance. How much I will pull centrally, how much centripetal force I must apply, and how much peripheral tendency I will have to get an adequate sized rhexis. So constantly I am in balance, and thus I've got a nice adequate sized capsulorhexis. Now hydrodissection. Little bit of hydrodissection. As the fluid wave reaches the other equator, is stop. And now viscoelastic substance is injected again. Now the tip of the phaco handpiece is introduced into the anterior chamber. I'm in bevel down position and I start aspirating this central hard part. In this case I have applied phaco energy, ultrasonic energy, very minimally, 2-3 times only, and rest of the time only vacuum was applied. That's it. In this case I am not going to do posterior capsulorhexis because the patient will cooperate for ear glazer capsulotomy. Now in this case we have selected a foldable intraocular lens. This is an unedited video. So here is the lens. The lens is placed inside the cartridge after irrigation. Both the haptics are placed anterior to the optic. And now the lens is injected into the capsular bag. Here it is. The lens goes into the capsular bag. This is a hydrophilic acrylic aspheric intraocular lens. And now the viscoelastic substance that has been used before implanting the IOL has to be nicely cleaned out. At this moment I am irrigating BSS in the antechamber as well as in the capsular bag. Most of the viscoelastic substance come out. Most of the viscoelastic substance comes out only by this irrigation. And now going through the side port and now I am going to introduce the irrigating probe of bimanual IA and doing some more irrigation. You can see a lot of viscoelastic substance is coming out. Now why both? Why both Simcoe cannula as well as this irrigation? It's because Simcoe cannula will irrigate in a controlled way, and this irrigates in a preset way. Now I have injected air bubble because antechamber is becoming shallow. To keep the antechamber formed, I injected the air bubble. Now I'm hydrating the side ports. In children, sometimes we need to suture the main incision as well as the side ports, but in this case the patient is an older child and I could seal the wounds just by hydration. Now I take the Simcoe cannula, do a final lavage of the antechamber under higher magnification, come down to the original magnification, and I've found that the antechamber is not nicely formed, so I formed the antechamber again. Now I checked whether the wounds are sealed or not, whether there is any leakage or not, and after ensuring that the wounds are sealed, I concluded the case. Thank you very much for watching. Hope this video will help you in doing your pediatric cases.